evening, and I really, oh, so happy to join you all this evening, and I'm really hoping that this is more of a dialogue than a lecture. It's late, and people get more out of things that are interactive, and it also lets me know what is of interest to you all to hear from you. So please feel free to unmute yourself and ask questions. We're a small enough group that I don't think that that would be disruptive at all. And I have a few slides for you just to tell you a bit about kind of my perspective and my lens. And so hopefully that'll help with informing the discussion. I will start off by saying I think you may end up getting different definitions of what community psychiatry is, like that. I am by no means the authoritative person on this. And so if you ask five people, you may get five different answers, but I'll tell you how I think about it. And with that, I will share my screen. So, having a conversation, as I mentioned about community psychiatry here, and I would like this to be as interactive as possible. So what is community psychiatry? So the way that I think about it, and I'm someone who thinks in terms of systems a lot, is that it relates to who you're taking care of and who is paying for it. So often when you're in mental health care, you have options, right? You can be in a private clinic, you can take private insurance, you can take fee for service. But if you're in a system that's relying on some sort of public funding, like the VA, like your safety net hospitals that get Medicaid dollars as well as dollars for taking care of indigent populations. If you're in a closed government system, like a correctional facility, where everybody is being treated not under any sort of individualized insurance plan, but on this group plan that the government, that the prison, that the jail is obligated to provide. And even places like classrooms where you have school health being administered, where again, it's public dollars that are at play and it's part of this public system. So when I think about community psychiatry, I think about systems. I think about, is the money coming from some sort of pooled resource and the population. So a lot of times in these settings, you'll have people who are all covered by the VA or all covered by safety net processes or that sort of thing. And so a lot of times, in some ways, it comes down to money. Now, I will say in terms of how you function as a community psychiatrist, right? Part of your role is to not only work within these systems, but often to be leaders, administrators, and help to shape how these systems look. But so much of your work is shaped and structured by how those systems are configured. So some of the things to think about, right, are patient population. And depending on which setting you're in, that population can change quite a bit, right? But a lot of times when you're talking about community psychiatry, there are populations that are either high risk or are marginalized in some way. With the most common form of marginalization, often being socioeconomic status. But if you look at something like the VA, then they're high risk because of their service and the trauma loading, and the people who go into the military in the first place tend to have more socioeconomic disadvantage than those who do not. But really, the patient population can be quite broad, right? Like it can be children in a juvenile justice facility, or it can be people in a VA nursing home. And so it does run the gamut in terms of who you may end up serving. The same is true for treatment modalities. A lot of times in publicly funded systems, it may be hard for the psychiatrist or the physician to be able to do therapy because a lot of times they're going to have you doing just psychopharm. But if you're in larger systems like a Grady hospital, which is our big safety net hospital, or the VA, you may be doing other things like ECT or TMS if those systems are able to support those things. And so in kind of traditional outpatient mental health in a public sector system, a lot of times you are going to be more limited just because of economies of scale and the way that healthcare works, that you may not be able to do as much in public sector settings. But once you get into larger systems, especially that are hospital-based, that get reimbursed at a higher rate, some of the treatment modalities may open up for these populations. So that takes us to treatment setting. So really, if you think about any societal institution where care is delivered, that would be considered a community psychiatry treatment setting. So that could run the gamut from a public health clinic to a pediatric primary care or an adult primary care setting, or even, as I mentioned earlier, like correctional settings. And then the administrative piece. What we're seeing happen in medicine, largely, not just in community psychiatry, is that with the rise and the increased use of advanced practice providers, physicians are taking on more administrative and supervisory roles. And I think that we've seen that happen at an even faster clip in publicly funded systems because of the financial pressures that are often on those systems. And as I mentioned earlier, in community psychiatry, since you're operating in the context of a system, it is important that there is solid physician input in terms of how that system works. And so I think there's ways that just kind of the environment of medicine is going to push more physicians into administrative work if they're in the community psychiatry space. But I would encourage those of you who are interested in leadership and management and program development to really pursue opportunities to train and get mentorship in that administrative piece. There's a saying by Deming, who's one of these, business book guys they quote all the time, but it's that a bad system beats a good person every time. And so being able to impact and affect systems change really does have significant implications across the board, not just for the people that you can see individually, and not just for the patients, but for the providers who are trying to take care of the patients in those kinds of systems. And then having a professional community. The events of last week and some of the programs that were cut, some of the populations that are going to be most affected are, prime community psychiatry populations. And last week was probably the most dramatic example that I've seen of that in my lifetime. But it's something that happens consistently with new legislation at a state level, at a county level, and what we saw last week was at a federal level. So there's a way that when you're working within a system, right, if there are shocks to that system, it reverberates down to the patients, it reverberates down to the providers. And so having people who are part of your professional community who can help you with anticipating those shocks and maybe trying to get ahead of them, helping you ride them out, helping you keep morale up as these things change is super, super important. In community psychiatry, because of the populations that tend to be in these systems, there is a really high loading of adverse social determinants of health that they are contending with. And the medical model doesn't always give us the avenues to address those social determinants. And so there can also be a moral injury and difficulty doing the work, which is another reason that professional community is so important in community psychiatry. So I'll tell you guys a little bit about my career and what it looks like. And again, this is for the purposes of illustrating how it could look for one person, but also for hopefully informing your questions in our dialogue later. So I went into medical school definitely with an interest in marginalized populations and Black populations specifically as well, and thought I was going to be a pediatrician, and then had this amazing lecture on addiction medicine by Mark Gold, who happened to be at my med school at the time, but is like one of the founding fathers of addiction medicine. And he got me interested in addiction and then in turn in psychiatry. And I shifted from wanting to be in pediatrics to wanting to be in psych, and then ended up doing general psych, child psych, and then forensic psychiatry. Because I am a first generation physician, I have benefited so much from mentorship and sponsorship. I have, throughout my career, placed myself in settings, namely Morehouse School of Medicine, but I've also been adjunct to other places where I can help people grow, where I can be to people what those mentors and sponsors have been to me. I've had an active psychopharm practice, but also an active psychotherapy practice. And I'm someone who actually has done systems work, and I've been appointed to 2 commissions by the governor of Georgia, 1 commission by the US Secretary of Health. And so I have been around tables where decisions were being made about things and being able to influence language around those decisions. But at the same time, even though I've done public sector work, I haven't done that exclusively. So I've had some private practice patients because in those settings, unlike in these systems, if I want to do psychotherapy with a patient, I can do psychotherapy with a patient, and I can see them twice a week if I want, because we're not bound by the system's rules in the same way. And at Cambridge Health Alliance, which is, I tell people, it's like the hippie Harvard program. It was a public sector hospital, but it had this really rich tradition of psychotherapy, of trauma-informed work, of treating people who are part of the community, but also people who were in grad school at MIT. So it was this really rich experience of the juxtaposition of community psychiatry with, high functioning people. And I realized that I really liked doing therapy. And I thought that doing therapy made me a better doctor altogether. With forensics, when you think about marginalized groups, the most marginalized groups in society are those that are involved with the justice system, right? Or the criminal legal system, because there's not a whole lot of justice there, if we're honest. And so I was someone who was interested in history. I was in a Black History performance troupe in undergrad at Florida A&M. I was always interested in journalism. I wrote for the newspaper when I was there too. I was interested in law. My mom's a former police officer, former child welfare worker. And so there's a lot of ways that forensics just made sense for me. And so I ended up doing a forensic fellowship after my child one. The interesting thing is I was actually planning to do child and then community fellowship, but the program director of the community fellowship left right as I was coming, and that fellowship was in a lot of flux. And our child chief at the time happened to also be the forensic chief. And so I ended up kind of pivoting back to forensics. But I would say, I think I've probably been able to shape more because of that forensic lens than I maybe would have been able to with an MPH or that community psychiatry fellowship. I've been able to train judges across the country about mental health, about interacting with people who have mental illness in their courts and helping them understand that the systems that they're the people they're giving orders to are trying to navigate. And kind of calling back to that administrative piece, I've definitely ended up kind of running things. So I have my private practice, which, I started, which I bought the building for, which, was just me at the beginning. I've started a forensic mental health consultation company that is multidisciplinary and has cases across the country. I was a program director, and now I'm the chair of the department. And so at this point, my actual clinical footprint isn't as big, right? It's a minority of my time. But what I am able to do is shape a culture and shape an environment where I'm growing other people who are, or part of growing other people professionally who are part of doing this work. And so it's been a really cool experience the past 2.5 years that I've served as chair of this department to bring in new people, to bring in new professional development opportunities, to expand our services to include some of the most vulnerable populations in our region, and to use really some of the administrative skills I learned from my private sector work in the academic environment at an institution that is very community oriented. And community psychiatry, as I mentioned, can look really, really different. And these are just some people that I've had as mentors that I would consider community psychiatrists. So in the top right corner is Dr. Joe Bona. He was a physician administrator. So he had an MD and an MBA. He was the chief executive officer of the CAB CSB, which is like the largest safety net mental health provider in the state of Georgia. And so we have different CSBs by catchment, but he not only worked there as the medical director, but then grew it and then ended up in the CEO role, but did a lot of state level advocacy work and taught me about how you think about not administration and leadership, but also relationships with people that you're going to be dealing with over time for a long period of time. Um, on the bottom left is Dr. Altha Stewart, who has had this really distinguished career as an administrator in like city healthcare systems. So before the age of 40, she was running the public healthcare system in New York and has also run systems in other cities. And currently she's at the University of Tennessee, where she leads a center for youth and families that is really going upstream, stepping away from the medical model and more of a community-oriented model that is really, really extraordinary. She's also the first and still only Black president of the American Psychiatric Association. In the middle is Trauma and Recovery, which is written by Judith Herman. And she's a psychiatrist who coined the term complex trauma. And she was someone who was providing care to people at Cambridge Hospital. And the literature, right, which was mostly written by men, was undercounting, not recognizing, not giving fair space to traumas that were experienced by women and children at the hands of people in their own family. So like domestic violence, incest, things like that. And she not only provided care, not only trained people like me, but also, wrote this book that literally has penetrated the world in terms of its language and what she brought in terms of understanding the traumas of this marginalized population. And then lastly, Anil Prem, who now does disaster response work, but was at the American Psychiatric Association for a number of years as part of their staff, and was instrumental in literally mentoring a whole generation of psychiatrists. So how it all fits for me, equity is huge for me and has always informed what I do. I'm obviously a Black woman, but I also grew up in a rural area of Florida. And part of what was so compelling to me about learning about addiction was that, my experience was that people around me when I grew up who had substance use disorders ended up in prison, not in treatment. And when I was in medical school, and I was rotating at this addiction unit, all the Black people had gone to jail and none of the white people had, and they were using all the same drugs. And so these issues of equity to me were really prominent in mental health. And there's a way that with mental health and the way that all the social determinants shape how people show up, that it's important to have, representation there. Work-life harmony was important to me, continues to be as well. I work a lot, actually, but I do things that I enjoy, and I'm very particular about how I use my time outside of work. My residents, fellows, my early career faculty who were my residents and fellows can all tell you that I sleep 7 hours a night. I work out 5 days a week. I vacation every quarter. And I do what I have to do in terms of work in order to be able to do that. And I'm also super particular with my time. And so I outsource a lot of things to give me more space for the things that matter. Mentorship and sponsorship is always important. So while at the same time I am very intentional about things like this, right, where I'm talking to people that are coming up, I also am regularly reaching out to the people who are ahead of me, like Dr. Stewart, like Dr. Prem, who are able to walk me through what may be next and help me think through things. Because as you progress, right, the questions you have are different. The questions I have as a chair are really different than the questions I had as a program director, which are really different than the questions I had as an assistant professor of psychiatry. The questions I have as an entrepreneur who now has a national company is really different than the questions I had when it was just me doing forensic mental health work. And so there's always the need for that mentorship and that sponsorship to help you with the next level of things. I am someone who really appreciates novelty and the ability to create things and to grow. There are some people who like reliability and perceived stability. And I say perceived stability because people think a W-2 job means you have stability, but they can fire you anytime. So I don't think that it actually is, but people like to feel like it is. But I am someone who values the ability to create an autonomy more so than reliability. And this was something I figured out about myself. So I knew I didn't take a full-time job until I took this chair position 2.5 years ago. I had never worked full-time for anybody else. I knew that I could not do the same thing 9 to 5, Monday through Friday. I knew that I needed to be in a position where I could have some control, where I could build, where I could create, because that's who I am. And so I would encourage you all to think about kind of how you're wired and who you are, and try to build a career that is in alignment with that and that fits with that, rather than trying to think that you have to fit something else. I honestly don't know anybody whose career looks exactly like mine, but it fits me, and I absolutely love what I do. And that's a part of the sustainability piece. For me, I thought really early on doing 40 hours a week of direct patient care in a community psychiatry setting would not be sustainable for me. And there are a lot of people who graduated around this time that I did who are now working for insurance companies. And not to knock insurance companies, but that is part of, I think, the issue of not doing this in a sustainable way. And so there were certainly some people at the institution where I am now, I think, who didn't quite understand me because I was part-time, at the medical school, but then doing these other things. And so to them, I might have seemed like I was scattered, right? But I was effective and I was doing things in a way that fit me. And I still love what I do. 20, no, 18 years. Yeah, 18 years after coming out of medical school, which is crazy to say out loud. And a lot of that is because I've been okay, listening to myself and knowing who I am and not trying to fit into some, predetermined box of what, my career is going to look like. The picture on the bottom left, I actually just got back from Jamaica. There was a wellness retreat for Black women mental health professionals that I attended. And I worked out and did meditation on the beach every morning. You're never, ever too busy to do those things. And so one of the things that I encourage people to do, and this is going to apply whether you're in community psychiatry or any form of psychiatry, because in psychiatry, you are holding people's trauma. And that's the same in private practice with the rich people too, trust me. That it is important that we make time for ourselves too. And that is it in terms of my prepared remarks. And I'm happy to answer questions or hear your comments or responses.
I can start us off with one question if people want to also drop questions in the comments or ask directly. But I was wondering, how do you, in addition to having mentorship, how do you handle that moral injury and frustration in the system, and how do you work in that system while maximizing care for your patient when there are all these limitations? What are some resources, I guess, that you use to navigate?
Yeah, so sometimes when problems are really big, we can get distracted by the big things and not pay as much attention to the little things that we do have control over, right? So thinking about things like, for example, in our resident child clinic, embedded into our template are questions about adverse childhood experiences, right, into our intake template. I hate that so many of our kids are dealing with housing insecurity and food insecurity, but we make sure that we know so that we can refer them to, resources. The other thing that's been helpful for me is I've always had some piece of what I'm doing or been open to or been allied with or been part of advocacy efforts. So it would have been very hard for me to just feel like I was only plugging into the system if I wasn't trying to do anything to change it. The other thing I'll say too is when healthcare is funded through the typical mechanisms, you're more constricted. If you're able to get grants, if you're able to get philanthropic funding, it gives you certain flexibility around how you interact with people and the things that you can do for them. So, for instance, our department currently has a grant with the local DA's office where our social worker is actually going to be able to see people before they get out of prison, help with the plan to transition them back into the community, and then continue to see them once they hit society. That is absolutely not possible with Medicaid funding, right? And so sometimes what can happen is grants, philanthropy dollars can help demonstrate a proof of concept, and that allows you to be able to, advocate for those things. There are things that can move at the state level, even in very red states, like mine, but it takes time, right? So things like integrated care billing codes or things like that, that we've been talking about for years. We finally got, reimbursed at a decent level, last year. But things like that can help as well. And then the community piece, always.
Thank you.
Hi, Dr. Vinson. Thanks for having this Zoom meeting, and this is just like a really great talk. So thank you for like the opportunity to like hear from you. I just wanted to ask more about like um kind of what the community setting can look like in different places. I know it kind of varies a lot, but you did talk about like kind of the themes being like in the VA system, et cetera. So if you could just talk more about that, and also your experience in working with like centers that like center care around homeless or undomiciled populations.
Yeah. So it's important to understand there are certainly overarching cultures, right? But there are going to be differences between a VA in Augusta and a VA in LA, for instance, right? And so much of your work experience is going to happen in microcultures or subcultures, and also be shaped by, who you're direct reporting to. And I'll say too, in public sector systems, how much physician input or leadership is part of that culture and of shaping the systems as well. Because sometimes what you see is people kind of cut corners around physician leadership in some of these resource poor, publicly funded systems sometimes. Um, I was an assertive community treatment or ACT team physician my first few years out. And ACT is people who have severe, persistent mental illness. A lot of them are returning from incarceration or coming out of state hospitals or things like that. And so that was the issue of people being undomiciled was certainly one there. The nice thing about the ACT team, though, is that you have a multidisciplinary group of people who can help with managing that, and you have the flexibility to see people where they are, right? So if they're at Auntie's house this week, then we go to Auntie's house, right? And so that was, I thought, like really cool work because the model was actually responsive to what people with high needs require in order for them to have like meaningful continued engagement. Um, I will say, as somebody, I'm from the South originally, grew up in Florida. I made it a point to do residency in the Northeast because I wanted to see what a more resource-rich environment looked like in a public sector setting. It is absolutely different, right? Like when I was at Cambridge, you couldn't discharge people to the street. That happens all the time in Georgia, right? So there are things about how the overall like safety net system works or doesn't, is funded or not, that are going to shape some of your experiences with this population. Um, as I mentioned, I was a child psychiatry fellowship program director, and if you look at fellowship fill rates across the country, they're really bad in the Southeast. And I think part of the reason why that is if you look at the 7 states that haven't expanded Medicaid. The bulk of them are here. But that also tells you about some of the other social services. So when you look at people's experiences with child psychiatry during general psych residency, they're seeing how all of these holes in these different systems are impacting families, and it can be overwhelming in terms of trying to deal with it. And so all that to say, it is regional. There will be subcultures involved. And one of the things that I really encourage people to do as they're going through residency, pay attention to the rotations you like. Be curious about why you like them. Is it the population? Is it the people you work with? Is it the setting? How does that fit with who you are? But you can learn just as much from the rotations that you don't like. And then based on that, right, try to shape something for yourself afterward. I feel like a lot of times residents are just kind of like plugging through and like getting through it. But like this is a time for you to really try things out and be curious about the path that makes the most sense for you and is most sustainable for you, as you go into your career.
Thank you. Yeah.
We have a question in the chat. Can you please clarify what the medical model versus the community model refers to?
So if you think about the medical model, right, you have a patient, they get a diagnosis and they get a treatment for the diagnosis. It's very individualistic based, right? We are not able to give prescriptions for uh, food, right? Like we're not able to get prescriptions for housing, and especially when it comes to mental health, but not only mental health, right? Those things are going to matter a whole lot more than Prozac or CBT. And so, in more community, in places that are operating from a community model, there's more intentionality around assessing the social determinants and the social drivers of the person's situation, understanding how that's contributing to their presentation and to the likelihood of them getting better, and actually being able to intervene on those different levels, rather than just thinking about, I, the doctor, diagnose you, the patient, and give you this treatment, right? We think about people more broadly. And, in some treatment settings, you may actually have the ability to do that. So if you look at something like, ACT teams, right? They have occupational therapists, nurses, peers, people who with lived experience with mental health. That's really different than me one-to-one giving you a diagnosis and treating you. When I refer to Dr. Stewart's program in Memphis, Tennessee, they are doing full wraparound services for families and showing up at kids' schools and literally coaching parents through meetings about special education so that their children get services. That is a more community-based model.
I have a question. Thank you so much for your presentation. I'm a fourth year med student in Michigan and applying for residency right now. So I was wondering how these experiences look in residency, and I'm really excited for the next two talks that are more focused on residency. But how would you recommend to get more of these experiences in residency, like in ACT teams and things like that? Or is it better to focus on like the inpatient and really getting those skills down first? Like, kind of how do you recommend navigating that?
Yeah, so the residencies have different degrees or levels of community orientation, right? So I won't say the name of the program, but I interviewed at one program in the Northeast, and when I asked about um, racial minorities, the interviewer said, "Oh, we have a contract with the NFL." Not the program for me, right? And there would only be so much that I could do from a community psych standpoint in a program where somebody answered me with that question, like seriously. So part of it is just the program you pick, right? Um, the other thing too, I'll say, is that being in a program where that is clearly something that people value means that the faculty who do that work will be valued. And so your ability to see somebody who is doing the work, is thriving, who enjoys it, who can mentor you and sponsor you in it, is probably going to be a higher likelihood in this sort of setting where, you know, that is part of like the ethos and the culture. You know, typically residencies, you're going to have an acute year, you're going to have an outpatient or an ambulatory year. So that's just, you know, par for the course. Most of the time, you don't get much elective time until your fourth year. But, you know, in most places, I think you get some. I ended up fast tracking into child, so I didn't have a fourth year. But that may be a time where you can explore more things. But if you go to a program that's not community oriented, they may not encourage you to do that, right? They may think you should be spending your time on something else, or you may have to really invent the wheel in order to get those, you know, those exposures. There are community psychiatry fellowships that could give you some of that exposure as well. Like I mentioned, I was planning on doing one when I came down here. Cambridge was a very community-oriented program. There's a lot about forensic psychiatry, or at least my approach to it, that is quite community-oriented. And I figured I should probably get a job, so I didn't do a third fellowship.
Hi, Dr. Vincent. Sorry, y'all. I am leaving clinic and driving, so I had to pull over real quick to ask this question. Um, so you were talking about the advocacy part of it, and that's something I'm very interested in. So I was wondering if you could talk a little bit about how you kind of got involved with the advocacy. Is it something that you did in residency, and kind of how did you navigate, I guess, putting your foot out there to do that? Because that's very interesting.
Yeah, so a lot of times we pay attention to like big APA, big ACAP, these national organizations, right? But they all have district branches or regional branches that may be like for the state, or even a state that's big like California, like by a region of California. And what you'll find is that a lot of times those organizations have infrastructure, they may have lobbyists on staff, and there's a way that you can kind of use that collective power that they have built over time to help raise issues. And so some of it has been through working with our like local chapter of APA, the GPPA. And then some of it has been really just showing up. So I mentioned to you guys, I never had a full-time job till I became chair. Not that I wasn't working a full-time set of hours equivalent, but I just never worked full-time for anybody. And part of why I did that is because I wanted to have a certain amount of autonomy over my schedule. So if I wanted to go testify in front of the child mental health committee, I could go do that. And I didn't have to ask somebody to do it. And I didn't have to ask somebody if I could say what I wanted to say. And so, you know, not being financially dependent on any single entity has also been, you know, part of my approach. Like, if Morehouse fires me tomorrow, I'm fine, right? And I have never like been in a position in my career where I was worried about that. And that's, you know, I think that's helpful. But what you'll find is that a lot of physicians, right, because we were put on this path and we just follow the path. So a lot of physicians end up working like full-time for somebody as soon as they finish. It doesn't give you a lot of space to show up. If you actually have the space to show up and you show up, there's not a lot of people who are doing it. So even like me in this package in Georgia, don't get it twisted, Atlanta is not Georgia. In Georgia, right? Because I was a physician who showed up, was able to make, you know, connections, have been able to get appointed to commissions by the governor, right? Because I showed up and I was the person that people knew, especially when it came to like children's mental health stuff. And so it sounds simple, but like just giving yourself space to show up can go a long way, actually.
Thank you so much.
You're welcome. And I'm honored you pulled over to ask a question. Wow.
Yeah, I was like, it was burning. I had to like pull over. I didn't want to pull on the side of the road, so I had to find a Dollar General.
Oh, David, you can go.
Oh, hi. I'm sorry. I just have a really quick, complicated question. Um, I'm a second year at a community program in Michigan, and I actually love it because we get to jump from different places and just see the population and the community. But my question is because I'm interested in child two and forensic, and a way to still keep the community aspect. How do you go about, you know, looking into programs where you can still have it? Because every place is different. And it's like, do you go to one facility, move and do 2 years here, and then, find another one for forensics that kind of has that same kind of aspect? Or do you just think it through and then, stay at one place and just try to do both of them with the mindset of like keeping community at the forefront of your goal and how you want to practice in the future?
Well, there's a few ways to think about that, right? So by the time you're in fellowship, you're thinking about life post fellowship, right? And so I do think that people consider more things about like being close to family and things like that when it comes to fellowship than maybe they did during residency. So that's one piece of it. Um, I'm pretty critical of forensic psychiatry, actually. I think that we have space to grow in medicine when it comes to incorporating structural and cultural considerations. And I think that's even more so the case with forensics. So I don't think there are a ton of programs where I'm like, they're hitting it out the park in terms of, um, obviously they're seeing people who are system involved, but really thinking about what that means for those people and for those populations. Um, so it may be hard to find both. What I would say is um, certainly some of the bigger schools are going to have both. And it could be that as a fellow in either program, I think generally speaking, you have a little bit more flexibility and you're more likely to have some elective time with fellowship compared to residency. And when it comes to fellowship as well, because you have more slots than applicants, you're going to have a lot more say so over where you go. And so it's not like residency where you're biting your nails, hoping you just match somewhere, right? Like in fellowship, like you're most of the time going to be able to just choose where you are. Um, I'll say that, my fellowship was not, we didn't have any formal teaching or instruction around cultural or structural issues. And when I would bring it up, there wasn't a lot of positive reinforcement or support around it. And I tell people that, like, I think I'm a good forensic psychiatrist. I learned some of the basics, like the operational stuff during fellowship, but I think the things that make me a good forensic psychiatrist are that I have thought about oppression and power and marginalization. I have read Toni Morrison and James Baldwin, and right, like I think those things are what actually make me a good forensic psychiatrist. And my company, I mentioned to you guys, I have a forensic mental health consultation company. A lot of my people are not forensic trained. I have just trained them because they had the substrate and the basic foundation of being really good clinicians who thought about people holistically. And I could teach them like the technical stuff around how you write a forensic report.
Thank you.
I often see the phrases like community psychiatry and public psychiatry be used interchangeably. In your experience, is there like any big difference between them, or is one like a larger umbrella term for the other?
Yeah, I mean, I think when you think about public psychiatry, it's systems where it's, Medicaid, Medicare, safety net dollars. I think community psychiatry could also be things that are philanthropically funded or funded through other systems. So I think it could be a bit broader than just things that are through public healthcare dollars as traditionally defined. That could count as community psychiatry. I'll give you an example. There's a doctor in the Bahamas named Dr. David Allen. He trained at Harvard years and years ago, and he has a private practice there. But he realized that a lot of people there, the Bahamas is an interesting like mix of people, like the expat community there. I ended up there for the mentor Mark Gold I mentioned earlier, like his 75th birthday party was was in the Bahamas last summer, and I went. So that's how I ended up there. But like ended up getting connected to Dr. Allen, and he does these groups that he calls the family, that are a way of giving people like a safe space and a way to connect. And he's doing this like group therapy in a church's unused room on a Saturday, with this really amazing like cross section of people. That is community psychiatry. There's no public dollars or Medicaid attached to it, but that's community psychiatry, and like it's coolest form. So yeah, so I think that sometimes if you say public, that you may be drawing some lines around it, that are that don't get everything that community could. But that's just the way I think about it. Like I said, if you guys ask other people, you'll probably get different answers.
I guess like kind of a follow-up question to that, because I'm still somewhat trying to wrap my head around different types of, hospital systems and whatnot, and government systems that uh, we have available. But would you characterize maybe public psychiatry then as having more to do with like a systems level management within like a hospital system, for example, of like different resources or departments?
Depending on the hospital, right? So if you're at a hospital in the suburbs of Atlanta where 20% of the patients have Medicaid, versus Grady Hospital, which is the safety net hospital, where most of the patients are Medicaid or uninsured, Grady would count as kind of public sector, community psych. Being at the hospital in the suburbs wouldn't, even though you could be an administrator at either one. So really, it's going to come down to population and funding source, and really what that institution is kind of oriented around, and who it serves. But there are all kinds of things you can do in psychiatry, right? Like, so there are psychiatrists who work for the CIA, who work in different outposts where CIA agents are stationed and take care of CIA people and their families. Right? Like if you think about just the human condition and the need for like mental health providers, you could end up inserting yourself almost anywhere. Now, there may be some times where that's already established, and there may be times where you end up creating that. Like I did some consultation for a startup incubator, right, around mental health and money and entrepreneurship and identity. That wasn't a rotation in residency, but it was something that I could apply, my skills as a psychiatrist to do and to help them with. So, it could be that the path is already there in certain institutions, but in a lot of them, there's a potential for the path to be made.
If we don't have any more burning questions, we can definitely end the session early. But thank you so much, Dr. Vinson, for being here with us tonight. It's, taking time out of your day, and so we really appreciate your lecture and being able to have this conversation about a super important topic. Um, I will be posting the recording on the PsychSign YouTube page. And so if anyone has any questions in regards to the lecture or Dr. Vinson, you can always email me and I can relay any questions.
Sounds good. Thank you, guys.
Thank you.